And to start us off with our first lecture, I'd like to introduce you to Johannes Mellinghoff, and his talk is on the basic anatomy and physiology of respiration. Welcome, Johannes.
Thank you.
Johannes, at the outset of your talk, I have a question I want to pose to you that I think all non-ICU nurses would be interested in. So my question is, why is it important that nurses understand normal respiration and the differences between how we breathe normally and how patients breathe in ventilators?
Thank you, Una, and thank you very much for the very kind introduction to this course. And I would like to welcome everybody who's participating. Now, in response to your question, I think it is very important to understand what happens during normal respiration in order to identify when things go wrong. And underlying pathophysiology, we will see in clinical practice that things go wrong while patients are ventilated with positive pressure through a mechanical ventilator. So first of all, I'd like you to show my learning outcomes for this session. So we will try to get you to recognize the principal structures of the respiratory system and identify the main anatomical landmarks. Secondly, we'll look at the understanding of principles of respiratory physiology. And lastly, hopefully by the end of this session, you will be able to conceptualize what happens during gas exchange and apply this to clinical practice. Most of this information is fairly basic, so you will already have some understanding of this. However, we think that it's important to bring it back to the forefront of your mind as we are moving through the more extensive sessions later on. So, what we need to understand in order to make assessments in respiratory assessment is the basic physiology. We quite often do this in clinical practice on a daily basis. We look at our patients, we will be able to see whether they're breathing fast, whether they're breathing slow, whether they're struggling with their breathing, just by doing just normal observations in daily practice and looking at our patients. In addition, we can do further investigations that may be asked by our medical team to do an X-ray, for example, or an ultrasound. So, our upper respiratory tract is responsible for the intake of the air through the nose or the mouth and humidify and clean this air initially. You can see that there are many different parts that belong to the upper respiratory tract that all have got important functions. As the air moves through the upper respiratory tract, it goes to the main bronchus. Here on the left side, you can see a diagram of what happens once it reaches the lungs. We differentiate the left lung from the right lung, while the left lung has 2 lobes and the right lung has 3. Both of those lungs are in our thoracic cavity. On the right side, you can see a depiction of a chest X-ray, which also shows you some landmarks within here. Within your thoracic cavity, at the bottom, you see the diaphragm. In the middle, you see the heart with the aorta coming out of it, and the 2 lungs on the left and the right. In the middle, you find the trachea. So as air crosses through the upper respiratory tract into the lower respiratory tract, passing through your trachea, it comes to the primary bronchi. Then the secondary bronchi, the tertiary bronchi, and the bronchioles and terminal bronchioles, as we say. Important to remember here is that we've got a place which is called the carina, which is here in the middle of the screen, as the right and the left bronchus will go to either side of the lung. Sometimes we find problems with our artificial airway that will lie within your trachea, going just into the right side of the lung. And as you observe the patient, you can see that actually only the right side of the chest is going to move. At the bottom, you find the diaphragm, and that has got one of the most important functions that we discussed further on. So the mechanics of pulmonary ventilation explain to us how air actually does flow into your lungs. In general, air will take the path of the least resistance. We are all surrounded by pressure, which we call our atmospheric pressure, which at sea level is 760 millimeters of mercury. During inspiration, our diaphragm will contract and will pull down. By that, reduce the alveolar pressure to 757 millimeters mercury, and by that, inspiratory muscles will contract and air rushes into our lungs. On expiration, the diaphragm will relax, and the inspiratory muscles will relax as well. By this, we will have an increase in intraalveolar pressure, and the air will rush out of our thoracic cavity. Here's a further depiction of exactly this. We've got inspiration on the left side of the screen and expiration on the right side, with the according pressure changes. So the diaphragm contracts, increasing the capacity of the thoracic cavity, and inspiration through muscle contraction takes place. On the right side, the diaphragm relaxes, reducing the capacity of the thoracic cavity, forcing air out. Inspiration as such is an active process, and we require energy in order to undertake it for our muscles. While the intrathoracic pressure becomes less than the atmospheric pressure, forcing air into the lungs. The ribs will elevate and the diaphragm contracts downwards, which you can see here by the depiction of the weight. Expiration, in contrast, is a passive process. We do not require energy in normal respiration, though be aware there are some conditions in which expiration will take place forcefully, for example, in asthmatic patients. So let's have a think. What are the factors and disease processes which will influence inspiration and expiration? I already mentioned one. In asthma, patients find it very difficult to breathe out. That means that the pressure inside the thoracic cavity will increase continuously. But what, for example, happens if you've got a cancer in your lung? If the cancer goes inside of your trachea, then you will find that there is a narrowing, impeding air entry and air movement. Other pathophysiological conditions, like chronic obstructive pulmonary disease and emphysema, will also have an impact on the physiology of your lung. And similarly, what we've all been speaking about recently is the acute respiratory distress syndrome and COVID-19, which will come with their own underlying pathophysiology. Now, let us think about gas exchange. We are differentiating between two types of gas exchange after we discussed ventilation of the lung, which is the external respiration. This is the gas exchange that takes place once air moves into the alveoli and goes over into your blood. And then the internal respiration, which happens at tissue level, which is the exchange of respiratory gases between blood and cells. Our alveoli that are at the end of the lung tree, essentially, have got several properties that are quite unique. Obviously, they've got the capillary bed that surrounds them, where gas exchange takes place through diffusion. So from the air that is in the alveoli, down the pressure gradient into the capillary. And that happens because there is very thin alveolar capillary membrane in which that can take place. Overall, Alveoli have a very large surface area, if we were putting them all together, around roughly 70 square meters for a normal person. There's only a small amount of blood volume distributed throughout the pulmonary membrane to enable maximal exposure. So we can think if there is a layer inside the alveoli, like for example present during pulmonary edema, it will be more difficult for oxygen to diffuse over into the capillary bed. Similarly, this might be the case of a mucus plug. So we can see here our alveoli and the pressure gradient from one side to the other. As I said, diffusion will take place of oxygen into the pulmonary vein because the pressure changes from within the alveoli to the capillary bed. At rest, tissue cells only need about 25% of available oxygen in the oxygenated blood. So if we think about checking a patient's oxygen level through, for example, a peripheral oxygen probe, and it shows us that there is oxygen of about 95%, if we take 25% away from that, we are left with 70% oxygenated oxygen on the right side of your heart as the blood is traveling back to your heart for reoxygenation. In the ICU, we sometimes can measure those things. During exercise, however, more oxygen diffuses from blood into the active cell, for example, while we are running or exercising. So therefore, more oxygen is required during those times. Similarly, when you become sick, for example, when you have a trauma or major surgery, or infection, what we are talking about here in terms of COVID-19 infections, your oxygen consumption will go up, anywhere between 15 and 35% in most cases. Another thing to remember when we talk about oxygen and how oxygen is being delivered to the vital organs in our body is that it actually is attached to hemoglobin. So if we have a very low hemoglobin, for example, in anemia, less oxygen is being carried to those organs. Only a very small fraction of oxygen is actually dissolved in plasma, and this is negligible in most cases. In order to understand what might happen and the problems that occur in some patients, this following graphic might give you a bit of an idea. On the left side of the screen, you can see that we have the alveoli here with air going into the alveoli, and there's a continuous exchange of carbon dioxide and oxygen with the capillary flow of blood. In the second part down here, we call this a physiologic shunt, because essentially there is no air within the alveoli, while the capillary blood flow continues. So no gas exchange is actually taking place. An example of this could be, for example, a big mucus plug that sits somewhere proximal, and therefore no air can go into that part of the alveoli, or bronchial tree. In picture C, you can see that air is still going into the alveoli from the outside, but there is a blockage of blood flow. This is what we call alveolar dead space. And if both of these conditions in B and C exist, we talk about a silent unit, as there is no blood flow and neither air in the alveoli. So let's think about patient in respiratory distress. We will all have seen patients struggling to breathe. Therefore, they may be breathless. Their work of breathing may be increased because they're using their accessory muscles in order to breathe in and out. If they are deteriorating a lot, their level of consciousness may also be impaired, or they may be in distress, sitting up, in bed, or in the chair, gasping for air. Their color may also be changed, in particular with regards to their lips or their fingers and nail beds. Is their general appearance changed in any way or form? What's their mannerism and posture? And can they talk in full sentences as you speak to them? In all those cases, we routinely collect quite a bit of important information, like, we already alluded to it, the peripheral saturation or the respiratory rate. All the other factors that I mentioned in the slide are also important and give us kind of an idea of how well or badly the patient is doing. So over to you. I hope you can apply some of this basic physiology and anatomy in your clinical area, regardless whether you are in intensive care or not. I hope I didn't bore you too much. Thank you very much.
So thank you, Johannes. An excellent presentation and a great refresher for me on the anatomy and physiology. So I was thinking, if I were a non-ICU nurse, what more would I want to know about? And so it's very clear that critically ill patients need positive pressure ventilation to support their breathing during their critical illness. But this alters the mechanics and the pattern of breathing, as you've discussed. So what effect does that positive pressure ventilation have on the patient's lungs, their heart, their kidneys, and other body systems, and how are these overcome?
Thank you for the question, Una. This is the reason exactly why you need to know what happens during normal physiological respiration and ventilation. As we use positive pressure ventilation, which means that we're putting a positive pressure and we are pumping air into your lung, physiological changes will happen within the thoracic cavity. This is something that we call the intrathoracic pressure. As the intrathoracic pressure increases, we may experience problems with venous return, which is what we call the blood coming back from the rest of your body to the heart. And we may experience a dip in the blood pressure. As the blood pressure decreases, so maybe the pumping of the heart and the amount of volume of blood that is being oxygenated being pumped back to the vital organs that we have. So patients may experience consciousness because of that. There may be a reduction in blood flow in your kidneys, and therefore a reduced urine output. Similarly, all functions within your gut may also be impaired. So you can see, knowing the normal physiological processes that keep us alive every day are impaired during positive pressure ventilation. Thank you.
Thank you, Johannes. Really, really good explanation there. Very clear, very simple and well described. Thanks again.
Thank you.